All right, well, hello. It is great to be back in Durham. Always great. This is the second time I've been able to give Grand Rounds since I left here in 2001. But it's a great honor to be invited by your alma mater to come back and present. And so for that, I thank you for the invitation. You know, we've had a long-standing pipeline, American Airlines pipeline between Dallas and Durham, sending people to and fro like mosquitoes migrating to the light, but many of us run away from the bug zapper and go back to Dallas, I guess. But you know, around my time, we had some success. We had John Warner was a contemporary with me. He's now CEO of the UT Health System, UT Southwestern Health System. Gail Peterson, a contemporary with me, is now Associate Program Director of our Internal Medicine Residency. So I came to Durham in 1997 with a focus and an intent to study diabetes and heart disease. And I can tell you there weren't very many people interested in diabetes and cardiovascular disease back then. And many of you probably are still not very interested in it, but no matter how little your interest is, we can't escape these patients. We were taught through residency that you had to hammer away at these type 2 diabetic patients to get their glucose under control, to save their kidneys and their eyes and their limbs. But I was never taught very much about cardiovascular risk of diabetes, and it was only around that time that we really began to fully appreciate the cardiovascular implications of type 2 diabetes. And looking into the literature, this was an expanding population of patients, although who could have ever expected this explosion that we have, that's the diabetes epidemic. And as that expansion occurred, we also realized more and more that this is a cardiovascular disease and we have to treat it accordingly, including but getting well beyond blood glucose control. And so I embarked on a training pathway that involved the master's program here in clinical research, empiric pragmatic training as a fellow on large-scale international clinical trials. And now I've continued to apply that both on population epidemiologic research, looking at care and outcomes of patients with diabetes, and most recently this explosion of randomized clinical trials that I'll finish up with, that I've been fortunate to be involved in a number of the trials. And so this is just one example of the cardiovascular implications of diabetes. Most of you are familiar with United Kingdom Prospective Diabetes Study, one of the very first and remains one of the cornerstone randomized clinical trials in diabetes. Now, this trial randomized patients at the point of diagnosis of diabetes, and so these are brand newly diagnosed diabetic patients randomized to a policy of more intensive versus usual care of their glucose control. This is about a median follow-up of 10 years, almost 4,000 patients. So what we have is a 40,000 patient year epidemiologic database to analyze. And so if you just break down independent of what their treatment, their randomized treatment assignment was, and look at what happened to these patients through the average 10-year follow-up period, blindness occurred in 3.5% of the patients. So that's a measurable number. It's not huge, but blindness is a catastrophe when it happens, and so that's important. And I will remind you, blindness in this trial was 2 or more lines dropping on a visual acuity scale, and so it wasn't complete blindness, but it was visual impairment. End-stage renal disease that gets so much attention for glucose control, 0.6% incidence over 40,000 patient years of observation. Amputation, pretty uncommonly, and if you add all those together, still about 8.5% incidence across all the microvascular disease complications. And contrast that with coronary artery disease. This is incident disease, so people were excluded at trial entry if they had prevalent coronary heart disease. And so these are all incident cases of coronary artery disease in excess of 20%. If you add stroke and revascularization, 1 out of 4 patients had a complication of macrovascular disease, about a 3-fold increased risk, macro versus microvascular disease. And so we can't ignore the microvascular disease, which is the imperative for glucose control, but we have to attend better to the cardiovascular risk. I will also point out, with a median follow-up of 10 years and a 20% plus incidence, this is coronary heart disease equivalency. Right? So these are back in the 80s, the early 80s through the mid 80s, and probably back then type 2 diabetes at its diagnosis was equivalent to coronary heart disease risk. We've done a lot better with risk modification, identifying these patients, and so probably right now diabetic patients that are well treated barely get to an intermediate risk, a 10% 10-year risk for coronary heart disease. That has implications when we're designing randomized clinical trials. The event rates have declined because our therapeutic interventions have improved. And so we have to take that into account when we get to clinical research. Now, this is the cardiologist picture. We hear all the time about the population prevalence of diabetes. It's now in excess of 10% of the U.S. population. Dr. Greenfield told me once as a fellow, I knew we were in trouble when the farmers got fat. And it's true. Everywhere you look is this epidemic of obesity, and with the obesity comes diabetes. And we see this all the time in cardiology cohorts. So these are 5 clinical cohorts in cardiovascular situations. And so on the far left, there's a study by Taubert. This is a large volume tertiary referral cath center in Germany. And they looked at every patient referred for cardiac catheterization independent of the indication. Right heart cath, left heart cath, valvular disease, coronary disease, didn't matter. And in the pretest holding area, they got a fasting glucose and did a 75-gram oral glucose tolerance test. And they were able to identify about 18% of unselected patients showed up in their cath lab already with a diagnosis of diabetes. But they found an additional 15% that had undiagnosed diabetes that would have remained undiagnosed had they not been in the study. And so 1 out of 3 unselected patients in Germany had diabetes. And this is important. You're about to shoot the coronaries. You're going to be making some revascularization decisions. And it's important to know whether diabetes is present or not to help guide those decisions. Muhlestein, this is Brent Muhlestein, who's a former Duke Fellow at Salt Lake City. This is the Latter-day Saints Hospital consecutive PCI database. They just went back and looked at fasting glucoses documented in the medical record around the time of percutaneous coronary intervention, and they were able to identify almost 20% of patients who had glucose high enough to meet present-day criteria for diabetes but were not diagnosed in the medical record with diabetes. And so these are cardiologists who are just simply not paying attention. As you know, everybody coming to the cath lab fasting, so these are all fasting blood samples. And so unselected patients having coronary intervention, 40%. So this 40% over 33% tells you the incremental risk for coronary heart disease. So these are obstructive coronary artery disease patients as opposed to all comers down here. Then if you look at an acute coronary syndrome registry, you see 1 out of 5 patients. This is a single center in Sweden, the Karolinska Institute in Stockholm. 1 out of 5 patients presenting with an acute coronary syndrome had previously diagnosed diabetes. Before discharge, they all got oral glucose tolerance testing and they identified 30% more patients, so the 50% incidence or 50% prevalence of unselected patients with acute coronary syndrome. This might be a little high than is the reality in the United States, but it's a pretty impressive number, and the fact that they identified 30% just by systematic screening before discharge is interesting. This is embarrassing because these patients got back by both their primary care doctor and the cardiologist referring them to bypass surgery. These are coronary artery bypass surgery patients. And the surgeons perioperatively were diagnosing diabetes about 5% of the time. These patients are even slipping through the entire system, primary care. And then this is just a more contemporary, to the Muhlestein data, more contemporary PCI database, and again showing in excess of 40% in Spain with diabetes. And so no matter where you look, as a cardiologist, you're going to have a prevalence of diabetes in your unselected clinical cohorts between 25 and 50% of all patients. Now, these are data we published toward the end of last year where we analyzed 1.7 million patients in the NERMI 2 through 4 database. These are consecutive patients enrolled in the NERMI registry just before its closure as it merged in with the NCDR. So we were able to identify from 1994 to 2006, these are prevalent diabetes at presentation with a myocardial infarction. So this is previously diagnosed diabetes. This doesn't include the people who may have been diagnosed during their sentinel event. So 1 out of 4 patients in 1994 rose fairly consistently all the way at least until 2003, where 1 out of 3, and that's fairly stable since then. But 1/3, 1 out of 3 unselected patients have type 2 diabetes when they come in with their heart attack. And so, again, very common in that setting. This is from the same analysis where we were able to show the secular trends in outcomes. This is hospital mortality associated with diabetes. Diabetes in the red, non-diabetes in the yellow. And the gradient of risk associated with diabetes is very clear here, with about a 33% increased crude or unadjusted increased risk for hospital mortality with diabetes. Interestingly, the yellow curve declines throughout the follow-up period, so that by 2006, the mortality had declined from about 12 down to 8%, fairly impressive decline in hospital mortality. But the diabetes patients' mortality declined even faster. And by that, I mean it's the first study that we are aware of where there's a closure or a trend toward closing the risk associated with diabetes, the incremental risk over diabetes. But despite that, there's still about a 15% incremental risk. And this is just hospital mortality. So this is very short target of time that we're looking at, 5 to 7 days at the most. So at least in the acute coronary syndrome setting in the hospital, we're doing a little better with these patients, but we're probably not doing so much better in the chronic ambulatory setting. So this is post-acute coronary syndrome. These are data from the Triton trial looking at prasugrel versus clopidogrel in acute coronary syndromes, and what they saw over an average follow-up of about 1 year was about a 50% increased risk with diabetes compared with no diabetes if you look at the 3-point composite MACE endpoint, or if you look at the net clinical benefit when you take the safety signal, about a 50% increased likelihood of adversity associated with diabetes by itself. Now, these are not adjusted for differences in the patient mix, but diabetes by itself portends, and all the baggage that it carries, these patients are sicker and they do worse over time. And so finally, framing the epidemiology before we get into the drugs to treat diabetes is these are just a selected group of lipid trials, statin trials in various settings. And so this is high-risk primary prevention, post-ACS, elderly patients, and primary prevention. And all of these studies, what I'm showing you here, are the statin-treated patients within the trial with outcomes stratified by diabetes status. And so what you see is if you give statins, and as we get left to right, we get more and more intensive with the statin therapy, you see a continued gradient of risk no matter what study you're in or what population you're studying. Again, a 50, 60, sometimes 70% increased risk when patients in these studies are treated prevalently with statins and antiplatelet therapy and aggressive blood pressure target. These patients are pretty well treated, and still this gradient of risk remains. And so it begs the question, what is leading or what is causing that gradient of risk? What's left that defines the patient with diabetes versus all others? Well, it can be hyperglycemia. That's what defines the disease. And it may be that hyperglycemia is driving some or all of this incremental risk. But the data don't really bear that out. And I'll show you some of the data and where we're going with that. These patients have high triglycerides, low HDL. They're inflamed. They have prothrombosis, both platelet aggregation and the proteofibrinolytic system is deranged. So there are all these other nuanced insulin-resistant phenomena that occur in patients with diabetes who have cardiovascular complications that may individually or in aggregate contribute. So there are a lot of plausible targets, one of which remains glucose, but it remains to be defined. So what do we know about glucose? We've all learned this. This is, I show my own data when I can, but there are 1,000 studies showing that there's a gradient of risk for cardiovascular disease and or atherosclerosis that is linear all the way well into the normal range of glucose and well into the normal range of hemoglobin A1C. This is our Dallas Heart Study. That's a probability-based population sample from Dallas. We knocked on doors and beat the bushes and found 6,100 Dallas County adults and enrolled them into an observational study called the Dallas Heart Study. About 3,000 of these patients volunteered to come to our center and have an entire day of phenotyping, cardiovascular phenotyping. So we scanned them from head to toe, doing DEXA body scans, CTs of their coronary arteries, and whole body cardiovascular MRI. So this is the coronary artery calcium data. So what you see on average, these are 44-year-old on average ambulatory adults in Dallas County. So if you lived in Dallas and you had a mailing address, you could be enrolled in our study. So 1 out of 4 patients had detectable coronary artery calcium in an average age population of 44. Clearly this was associated with age, but even some of the younger folk had coronary calcium detected. If you stratify that population by normal blood glucose, impaired fasting glucose, study detected diabetes, and so then the orange here are patients that didn't know they had diabetes until they got into our study and we tested them and told them they had type 2 diabetes. And then the patients with prevalent medically treated diabetes are way up here, over 70%. But even in the impaired fasting glucose, you see this uptick of about a 50% increased likelihood of having detectable coronary artery calcium and about a doubling of risk if you have incident diabetes. And so this linear or log linear graded association goes down into the impaired fasting glucose or prediabetes range. So this underpins the biologic plausibility epidemiologically that hyperglycemia may be the causal factor. And as you'll see, I'm building the straw person here that will spend the rest of the time blowing down. One of the very first large-scale randomized multi-center clinical outcomes trials in any domain of medicine was this UGDP trial. This was the University Group Diabetes investigators who did a large-scale, at the time, 1,000 patients, multi-center randomized trial, and randomized patients with type 2 diabetes with one of 5 different treatment strategies. You only see 4 here. The 5th one was fenformin, and fenformin was quickly observed to cause lactic acidemia, was withdrawn from the market, and that arm was halted in this trial. But these patients got tolbutamide. This is a first-generation sulfonylurea medicine. They got insulin variable treatment. This is very close to present-day tight control with multi-dose insulin. insulin standard was 5 or 10 units once daily of insulin, effectively an insulin placebo. And then back in the 1970s, they actually did placebo tablet trials. So there was a cohort of diabetic patients who were treated with placebo. And what you see here in the yellow is the acceleration of mortality, both all-cause and cardiovascular mortality, that begins to separate around year 3 and continues throughout the follow-up of the trial. This is tolbutamide. It's the first-generation sulfonylurea. And so the conclusion from this trial was that tolbutamide increases all-cause and cardiovascular mortality. But look at these numbers. There are fewer than 100 total mortality events and only about 60 cardiovascular deaths and stratified over 4 different treatment groups. The precision of these estimates are very imprecise, yet this signal can't be ignored. Well, at the time, in the 1970, all we had was insulin and tolbutamide. And so if the FDA took this off the market, then we'd only have insulin to use to treat these patients. And so instead, the FDA chose to put a product label warning that said oral drugs to treat glucose are associated with increased cardiovascular mortality. And as funny as that seems, it was this sign of the times, but interestingly, this same warning is in every sulfonylurea marketed today in the United States. So if you ever prescribe a sulfonylurea, you're giving a patient a drug that has this in the product label today. Whether it should be there or not is debatable, but it's still there. We don't know. We have no idea about the cardiovascular effects of sulfonylureas. So getting back to the UK-PDS, I talked about this trial earlier, about 4,000 patients, median follow-up, 10 years, newly diagnosed type 2 diabetes, more intensive versus less intensive glucose control. The primary endpoint of this trial was a 14-component composite endpoint that included macrovascular, microvascular, and non-vascular endpoints, 14 components, unprecedented, never seen anything like it. But adding all those things together and calling them diabetes-related endpoints, a 12% relative risk reduction that did achieve statistical significance. So more intensive versus less intensive. Again, the A1Cs achieved here were 7.9 versus 7%. So this is the basis of the recommendation for a target of 7% for glucose control in type 2 diabetes. A lot of dust was raised by this signal for myocardial infarction, just barely missing statistical significance, a 16% trend towards reducing myocardial infarction risk. But what's never discussed or seldom discussed is that stroke went quantitatively in the opposite direction with 11% increased stroke risk. And so if you do myocardial infarction, stroke, and cardiovascular death, you get a point estimate that's close to 1.0, that you actually have no harm and no benefit detectable. And you can see here the microvascular disease. And this observation from UK-PDS is the underpinning of the present-day regulatory strategy for drugs for diabetes that we'll be discussing. And so whatever drugs for diabetes for blood glucose control do to the cardiovascular system, there's a faith that lowering blood glucose will favorably affect microvascular disease. And so on that backdrop, we just have to prove that the drugs don't harm people as opposed to benefit them from a cardiovascular perspective. So to date, this remains among the strongest clinical evidence for outcomes benefit with any glucose controlling agent. And this is metformin. So if you were overweight or obese at the time of study entry, you were eligible to be randomized to get metformin in the tight control arm of UK-PDS. This was a prospective randomization, not a post hoc analysis. And what they showed in this study is there was a statistically significant 39% reduction in myocardial infarction and a 50% reduction in coronary death. But if you look at the numbers of events compared, there are only 52 coronary deaths and fewer than about 250 myocardial infarctions to analyze across this study. So these are larger than anticipated and probably unprecedented in cardiovascular medicine. And given these small numbers of events, this is probably a statistical fluke to have such a large estimate of treatment benefit, but it goes in the right direction, certainly no harm observed, and based on this, metformin remains the first-line drug for type 2 diabetes. And interestingly, we see in the UK-PDS trial, what I will show you over and over again henceforth, is the absolute bidirectional invalidation of hemoglobin A1C as a surrogate for cardiovascular risk. So what we see in UK-PDS, the sulfonylureas and insulin that lowered A1C by 0.9% had no statistical difference in these endpoints. Metformin, which lowered A1C by only 0.4%, had 3 times the magnitude of benefit. And so lower A1C, bigger benefit, and vice versa. And so we're bidirectionally challenging hemoglobin A1C. So then we fast forward, it's not until 1997 when we get some new drugs on the market. Troglitazone, the first of the TZDs, came online in March of 1997. 2 million patients treated in the first 3 years in the United States alone. Acute liver failure was detected in post-marketing surveillance in 94 patients, 61 deaths. Several of these, the balance here, underwent liver transplantation. This was fulminant hepatic necrosis, and this drug was withdrawn from the market. So a safety signal that was actually, the signal was present in the preclinical testing. It just was not acknowledged or paid attention to very much. Since that, the PROACTIVE trial, this trial randomized patients with long-standing type 2 diabetes and at the point of study entry, macrovascular atherosclerotic disease, randomized these patients to get a targeted dose of pioglitazone, not titrated to A1C, but just a 45 milligram dose versus a placebo. This was the first ever in the field of diabetes, type 1 or type 2, the very first ever clinical outcomes trial, which is stunning, in 2005. Before this, never before had there been a clinical outcomes trial. The DCCT trial in type 1 took photographs of retina and measured albumin in the urine. So these are not clinical outcomes. So PROACTIVE was the first clinical outcomes trial, over 1,000 macrovascular events detected. Point estimate of 10% risk reduction with pioglitazone versus placebo. A point estimate that barely missed statistical significance. So this is the primary endpoint of the trial, and at the day's end, statistical purity will tell you have to interpret this as a negative trial. It failed to achieve statistical separation of the primary endpoint. Many of you are aware the 3-point composite MACE, the heart attack, the cardiovascular death, MI, and stroke endpoint actually did achieve statistical significance, making the PROACTIVE trial probably the most robust evidence in the field of diabetes for cardiovascular risk reduction. And we've gone down a pathway that's been very confusing ever since this trial, as you may well know. And this is where that pathway gets confusing. And so around the same time as PROACTIVE, rosiglitazone, the other TZD on the market, was being tested in the ADOPT trial. This trial randomized very much like the UKPDS. Just over 4,000 patients randomized to one of 3 different treatment strategies, rosiglitazone, metformin, or glyburide. And the primary outcome of this trial was durability of glucose control, measured both by fasting glucose and by hemoglobin A1C. And as you can see on this slide, rosiglitazone was superior by 5 years, was superior both to metformin and to sulfonylurea, in this case glyburide. Rosiglitazone was superior for both fasting glucose and hemoglobin A1C. But in that same trial, where cardiovascular events were captured through safety reporting, so this was not a cardiovascular outcomes trial. The events were not prospectively collected. They were not centrally adjudicated. They were not even prospectively defined. So this is safety reporting analysis. But what it shows you is that there's numeric excess for rosiglitazone compared with metformin and glyburide for both heart attack and stroke, heart failure incidence, peripheral vascular disease, and if you add all the cardiovascular, this barely misses statistical significance. So rosiglitazone, the signal, the writings on the wall here from the ADOPT trial that led to the meta-analysis and the further scrutiny of rosiglitazone, represented here Dr. Nissen's landmark article in 2007 that looked at all of these data, over 27,000, over 28,000 patients, over 27,000 patients in the registration program for rosiglitazone. Despite 27,000 patients, they had a total of 158 myocardial infarctions and 61 cardiovascular deaths. So this tells you they're studying the healthiest of the healthy, and they're studying very short periods of time, and they don't have an opportunity to have myocardial infarctions and cardiovascular death. But based on this analysis, a statistically significant increased risk for myocardial infarction with rosiglitazone, and mortality, that cardiovascular death that barely missed statistical significance. So a very strong safety signal. Summarized here on the left for myocardial infarction. This is GlaxoSmithKline's own patient-level time-to-event meta-analysis, the purest of the pure meta-analytic methodologies. And what they showed was a statistically significant 31% increase MI risk with rosiglitazone, contrasted completely with about a 19% relative risk reduction with pioglitazone. So same class, similar names, similar mechanism of action theoretically, but doing quantitatively different heterogeneity of effect is the newer term of interaction, is heterogeneity of effect. So pioglitazone looks fairly good. Rosiglitazone's taken off the market based on this. And then finally, this drug, miraglitazar, dual PPAR alpha gamma agonist, actually came before the Endocrine Metabolic Advisory Committee, had a unanimous vote for approval. And from the time of the voting of the Endocrine Metabolic Advisory Committee and the FDA's decision, Steve Nissen published this analysis in JAMA. showing an excess of cardiovascular events, death, MI, and stroke, 35 versus 9 events in the entire registration program, 44 events. 50 versus 11 when you add TIA and CHF. And so there's numeric excesses that couldn't be explained. And so based on this, despite the unanimous vote of approval, the drug was abandoned, thrown away, never saw the light of day. And so finally, these are the last of the data I'll show you from the accumulated trials to lay the landscape of where we are. Basically where we are is we have no idea what we're doing with cardiovascular disease and glucose control. I've shown you the proactive data already. This is a 2% absolute risk reduction and a point estimate of 10% relative, and again, barely missing statistical significance. And we'll come back to that, but what you see on the very bottom line here is I've shown the 95% confidence interval, and I'll call your attention to the upper confidence limit, 1.02, 1.04, 1.0. These are all very small confidence intervals. So at the very least, one might claim that there's no strong safety signal here. The upper confidence limit's 95% certain it's 4% or less. So the ACCORD trial, the large NIH trial, this trial was stopped early for excess all-cause actual mortality. But despite that, the 3-point composite myocardial infarction, stroke, and cardiovascular death actually went in the right direction with, again, very much like the proactive trial, a 10% point estimate of risk reduction and pretty narrow confidence limits over 600 events accumulated. The ADVANCE, a larger trial done largely in Australia, New Zealand, Asia Pacific, a 0.6% absolute difference, a small, probably clinically irrelevant absolute difference, and again, not statistically significant. So negative trial, negative trial, negative trial, we're not impacting cardiovascular disease. VADT similarly, this is a VA population similarly negative. Contrast that with the UK-PDS. Again, this is the trial I described earlier. 10 years of average follow-up, newly diagnosed type 2 diabetes. These patients were followed for an additional 10 years off protocol. And during these additional 10 years, there was continued separation, so-called legacy effect. I don't think it's a legacy effect. I think if you mitigate atherosclerosis development early on, you're going to limit its cardiovascular complications later on. And so this is approaching a 3% absolute risk reduction, and with metformin, 7%, almost 7%. This is larger than we typically see with cardiovascular disease. These are highly statistically significant, both for the tight control with insulin or sulfonylureas and importantly with metformin. So this underscores the concept that metformin should be the first-line drug. And finally, a meta-analysis of everything I've shown you so far. A meta-analysis of these studies show a statistically significant 15% myocardial infarction reduction and neutrality with mortality. So it's not a huge home run, but at least this looks reasonably safe if you're an optimist. And so based on all those data, in 2009, the ADA, AHA, and ACC got together and made some recommendations that we think that the goal of A1C less than 7 remains prudent, but not lower. And we shouldn't be treating blood glucose to attempt to mitigate cardiovascular risk, at least not in advanced patients. And the less advanced or uncomplicated patients, for example, like may have been enrolled in UK-PDS, more intensive therapy may be reasonable, and certainly this is a 1A indication for all comers. But if they're sick with macrovascular disease, for example, the level of recommendation is quite modest, 2B. It's reasonable to consider. It's not that it should be done, it's just reasonable to consider it. And again, the level of evidence I think is overestimated here to be A. Acknowledging there's incremental microvascular benefit with more intensive control, but it comes at a cost of potential cardiovascular risk, and so you have to balance the risk of the patient with the risk of the intervention. So we've gotten to this point by approving drug after drug after drug after showing that it simply lowers hemoglobin A1C, never requiring proof that it makes people live longer, feel better, or both. So no clinical outcomes so far to this point. In 2008, we have all drugs for diabetes approved exclusively on the proof of concept, A1C is reduced, and absence of a prohibitive safety signal. And so because of that little bit of data we have for cardiovascular disease, peppered throughout all these product labels are all these little cardiovascular warnings. As I mentioned, the sulfonylureas still to this day have this warning that these drugs may be associated with increased cardiovascular mortality. Metformin confuses everybody. I'll say it now, and we can talk about it later if you want. Metformin does not cause lactic acidemia. Does not. We have a petition in front of the FDA now to remove the renal warning or liberalize it substantially. We don't have to hold it for contrast. I'll stop here and say these are not just off-label, these are against label in a CME presentation, but there's movement afoot, and we're about a decade behind the rest of the world in this. And because of the fact that metformin doesn't cause lactic acidemia, the FDA in 2008 removed the heart failure warning in the dark of the night without any fanfare. So the heart failure warning is gone, there's no contraindication, and there really shouldn't be a contraindication in CKD, and we don't really have to hold it for contrast. The thiazolidinediones have been a mess. Pioglitazone looks mostly favorable. Rosiglitazone causes MIs and has been removed from the market. Both of the drugs cause signs and symptoms of heart failure by plasma volume expansion, and that continues to be a concern if you're going to be treating patients with pioglitazone or managing patients on pioglitazone. They may well have plasma volume expansion. There's no detectable signal for cardiac toxicity. Cardiac function and structure is not adversely affected with these drugs. Now, I got into this field by ischemic preconditioning and sulfonylureas and ATP-dependent potassium channels, and I still to this day believe that sulfonylureas should not be prescribed to humans. And this is recent data that actually supports my bias, and it is a bias, and there's, for every piece of evidence I have supporting my claim, I will acknowledge that there's equally strong, or I would say equally weak, data on the other side. So I don't know who's right here, but I'm still very concerned about these drugs. And this is a Danish, this was just published in the summer of 2011 in European Heart Journal, where the entire country of Denmark has a single medical system, capture of all diagnostic codes, and capture of all prescriptions, not just prescribed but filled. And so these are patients prescribed the drugs and who are actually taking them. And these are analyses of all-cause mortality based on the prescription for the glucose-lowering agent, with the referent here being metformin. So metformin is the comparator. Glimepiride statistically increased odds for dying, glimepiride versus metformin. Glibenclamide, this is what we call glyburide in the United States. So glimepiride, glyburide, glipizide, and tolbutamide all have signals of excess mortality. Now, this is not randomized trials. And so these are observations of association. We don't know. But interestingly, in Denmark, there's no cost difference. These are all covered by the national formulary. And so this is physician difference and maybe a little bit of patient mix variance in these drug prescription, but pretty much they're the same drug to drug. Also, these are multivariably adjusted and propensity score adjusted point estimates. And so what you see here is after adjusting for every way you can, there still looks like there's the signal of sulfonylureas causing excess mortality. And that doesn't matter whether you've had a prior myocardial infarction or not. These signals exist. The exception is gliclazide, which isn't available in the United States. Interestingly, gliclazide was the prescribed sulfonylurea in the ADVANCE trial. Remember, the ADVANCE and the ACCORD trials were parallel. ACCORD was stopped early for excess mortality. ADVANCE went to completion with no signal for excess mortality whatsoever. The difference between those trials, the primary one, is glimepiride was used in the U.S. and gliclazide, that looks pretty good here, was used. So I personally think the ACCORD trial, the mortality signal is exclusively due to glimepiride being used in excess. And it was excess case fatality of myocardial infarction. Completely speculative, and it's cherry picking to my advantage, and I will acknowledge that fully. So we published, with Silvio Nzuki, an endocrinologist at Yale by invitation of Circulation, we published in 2008 an algorithm for cardiovascular patients for the treatment of blood glucose in type 2 diabetes. We said at the time we agreed completely with the Endocrine Society's metformin on top of lifestyle should be first line. We went out on the limb and, acknowledging all of its baggage, still think, and I still think today, that pioglitazone should be the second line drug used based on the evidence accumulated. We put all of the unknowns in one single box. Secretagogues, those are sulfonylureas and meglitinide drugs that cause insulin secretion. Alpha-glucosidase inhibitors, the newer agents, DPP-4 and GLP-1, don't even have SGLT2 inhibitors on here we'll talk about, and insulin at the end. The only thing I would change if I had to publish this today is I would move the injectable GLP-1 analogs and the tablet DPP-4 inhibitors up ahead of all the others based on the accumulated evidence and our scrutiny of cardiovascular outcomes during their development. So we're getting more and more rigorous information about these drugs. It's all very early on, but I think they've risen above all others. And so most recently, I had the great privilege of being the only cardiologist in the world to review this document from the ADA and the EASD, and Dr. Nzuki, who's a close friend and collaborator of mine, is the lead author here. And I think the Endocrinology Society got it right this time, where not one size fits all. It's opposite as they're advocating in the most recent document. It's inverse to what we do with LDL cholesterol. That is, as the risk increases for cardiovascular risk and diabetes, your intensity of therapy should decline commensurately. Unlike LDL, with increased risk, increased intensity of therapy. And that's because the people at the higher and higher risk suffer or have higher and higher risk of the complications of the therapy and less and less likely benefit. And so what the ADA and EASD says, there are patient characteristics. Can the patient manage themselves? And if they can, more stringent. If they can't, less stringent. And I would put the numbers 7% right in the middle as an A1C target and 8% as an acceptable target for patients who fall to the right here. And I'll just point your attention down to this next to last one, established vascular complications. Severe, few to mild, we're getting 7.58%. And in the text of the document, they say patients with prevalent cardiovascular disease, a target of 8% or even higher is reasonable. And so as cardiologists, we can take one step back, at least until we have further data about safety of these interventions for cardiovascular risk. So how did we get to this complete chaos in the field of diabetes, which exists today? I'm not going to show you any data that's going to change what I've already shown you. We have no idea what we're doing, the treating blood glucose when it comes to cardiovascular disease. Well, most importantly, the FDA, up until February of 2008, the FDA only required 1,500 total subjects to be exposed to a compound before it would be approved for use in humans for a disease that lasts a lifetime. Only 300 to 600 for half a year, and only 100 people had to be exposed for a year. So we're talking probably around 1,000 patient years exposure max for this disease that's so severe. Well, as you know, the FDA's rapidly changed their perspective on this, and it's because of a few things, I think. Diabetes is common and increasing, a disease that affects 10% with these cardiovascular complications, 10% of the U.S. adult population. We have to better understand what we're doing with regards to morbid and mortal outcomes. And we understand more and more that it's a cardiovascular morbid and mortal disease. Up until 95, we only had these 3 drugs available. Actually, glucosidase inhibitors weren't even there. They came on in 1995. So 95, only 4 drug classes. Now we have, this is out of date, we have 38 formulations in 12 classes to choose from now. So we have this plethora of drugs to choose from to treat these patients, still not knowing what any one of them do for cardiovascular disease. And as I mentioned earlier, hemoglobin A1C has been bidirectionally invalidated, and so we can't rely on A1C to predict the patient's cardiovascular outcomes, and certainly can't look at small A1C studies and predict safety signals. February of 2008 incremented the data from about 1,000 to about 3,000 patient years of exposure required, but rapidly 10 months later the shoe dropped proper, and now we have cardiovascular requirement for cardiovascular assessment of all drugs for diabetes. The FDA states that you have to demonstrate that therapy will not result in an unacceptable increase in cardiovascular risk. You don't have to show that you make things better, you just can't make things worse. And that's on the backdrop again of the microvascular disease risk reduction that's assumed. The FDA advocates meta-analysis strategy across all of the trial registration project, phase 2, phase 3, including higher risk subjects, those that we'll be treating in the clinic space. So we need older people, we need ethnic minorities, we need people with chronic kidney disease that's so common in diabetes. And so we have to get these patients that are more representative of the patients we'll be treating. And then finally, a minimum exposure of 2 years of the compound. This is just a quick diagram of the tiered approval strategy. So the FDA now requires to come to market, you have to have an upper confidence limit below 1.8. And that's represented on the far right, this vertical dotted line. So the way you may achieve that is you can have a drug that has no harm and no benefit, complete neutrality, and you'll need about 80 cardiovascular events to get there. If your drug reduces risk by 20%, you'll only need about 60 cardiovascular events. And if you're down in this range, you'll need over 120 events to eclipse this signal. So in the context of cardiology, where we're doing trials of 3,500 events, this pales by comparison, but at least it gets you in the ballpark. This will allow drug approval with the contingency that you have to perform the definitive non-inferiority assessment post-marketing. And so there's a time clock ticking, and the companies are required to now show a non-inferiority margin of 1.3. That is, with 95% certainty, the drug is no worse than 30% worse. But all of the trials are designed based on the assumption of neutrality with the hope of superiority. And so we're doing these trials that are ongoing because we really want to show that something works. And of course, the endocrine community and the drug companies all cried foul. Sky's going to fall. There's no way we can afford to do this, and it's just going to break us. And it turns out that we've actually been down this road before. Does anyone know who this guy is? Ray Lipicki. So Dr. Lipicki took over the cardiorenal panel at the FDA around 1972. And when he took over that panel, he said from this day forward, to be approved for cardiovascular indication in the United States, you have to prove morbid or mortal improvement. No exceptions. And so Dr. Lipicki in 1972 made this switch, and now, whatever, 40 years later, we have the luxury of cardiovascular outcomes trials data for everything we treat almost. And that's because the FDA required it. And so we're just getting there with diabetes. Sure enough, drug development didn't halt. These are just a few, or not few, it's most, of the novel targets for therapies for type 2 diabetes. There are something like 27 novel therapeutic targets being probed presently, at least in phase 1 human investigation for lowering blood glucose in type 2 diabetes. These represent the ones that are already in ongoing phase 3 randomized clinical trials. These trials are between 6,000 and 19,000 patients, and these are being definitively studied. I'll just briefly mention a couple because of their excitement from the cardiovascular perspective. This incretin hormone that's secreted in the proximal small gut and facilitates glucose-appropriate insulin secretion also has effects in the brain, reducing appetite, on the stomach, slowing gastric emptying, making people feel full, eat less. So lots of benefits. They cause weight reduction, but importantly for the cardiologist, this receptor for GLP-1 is all through the cardiovascular system. So they're on smooth muscle cells and endothelial cells of the arterial vasculature. They're on the endocardium, staining here in green. They're on the cardiac myocytes. And so there's plausibility that this compound, GLP-1 analogs, may have direct cardiac effects. Whether they're good or bad, we're going to have to find out. But there's plausibility. Now, we've been down this road before. I can show you exactly the same slide of the PPAR gamma receptor. Right? And rosiglitazone looked so great, and pioglitazone looked like it would save lives left and right, and pioglitazone's a little bit good, and rosiglitazone hurts people, so we can't be too enthusiastic, but the early data are suggestive of some optimism. So these are meta-analysis. These are 5 tablets, the DPP-4 inhibitors. These inhibit the endogenous degradation of GLP-1, so this potentiates endogenous GLP-1 activity. Sitagliptin, allogliptin, saxagliptin, linagliptin, 4 drugs approved in the United States. Once daily tablets, almost no hypoglycemia. And the meta-analysis of cardiovascular effects range anywhere from about 15% down to 40% relative risk reduction. Very small numbers, very imprecise, but some optimism. These 2 are GLP-1 analogs that are injected. Exenatide is twice daily. A long-acting form is now being studied, a trial coordinated by the DCRI, once weekly, and liraglutide once daily injections. Again, these injectable forms cause people to lose weight, lower blood pressure a little bit, little or no hypoglycemia, so lots of favorable signals in the cardiovascular space. And then the final novel mechanism, the first drug approved just 6 weeks ago in the United States, canagliflozin. Canagliflozin is an SGLT, a sodium glucose transporter 2 receptor antagonist. So in the proximal tubule of the kidney, there's a high affinity, high throughput receptor that reclaims filtered glucose back into the circulation. If you inhibit that receptor, glucose stays in the urine and it's excreted with glucoseuria. And so this really just resets the glucose threshold for excretion. When you excrete glucose in the urine, you have 2 secondary effects. One is you lose 300 to 400 calories a day through the urine. And so these drugs are very potent weight loss drugs. The second thing is it's an osmotic diuretic. And the osmotic diuretic effect of these drugs is fairly comparable to maximum dose thiazide diuretics. And so you're getting blood pressure reduction, weight loss. Because it's independent of insulin, you can actually theoretically give this to type 1 diabetes, although it's not being developed. So these drugs inhibit the glucose reclamation and cause glucose spillage. There's discordant data. They have a little bit of adverse effect, or at least one of them, canagliflozin, has an adverse effect on LDL cholesterol. There's a stroke signal with canagliflozin. Despite that, it was approved by the FDA, which is interesting in and of itself. And there are 2 other compounds that are in advanced phase 3 testing. So here's the proof in the pudding that the sky is not falling and that the drug development hasn't halted. In fact, presently we're enrolling or have enrolled 175,000 patients with type 2 diabetes in dedicated cardiovascular outcomes trials across the spectrum of drugs we've talked about, the TZDs, the DPP-4 antagonists, the alpha-glucosidase inhibitors, the GLP-1 analogs, a novel mechanism here, GPR40. This is a G protein coupled receptor in the liver. So all kinds of things being probed. These trials have completed enrollment, and so the first one out of the box will probably be the SAVOR-TIMI 53 that should be reporting fairly soon, and several to follow fairly quickly thereafter. I'm just going to skip these in the interest of time and just summarize. As a cardiologist, I've talked a lot about glucose, but the money is in cardiovascular risk reduction with drugs that we know work. So aspirin for patients with indications. This says 75 to 162. I think almost everyone has adopted finally the low-dose aspirin, 81 milligrams a day for high-risk primary or secondary prevention. A statin for every patient with type 2 diabetes age over 40, independent of the LDL cholesterol. There's literally no discernible LDL that's too low that we can find. And so everybody gets a statin if they have type 2 diabetes. And blood pressure target is debatable, but I still believe it should be more intensive than average at less than 130 over 80. And if you do all these things, I've never seen a trial so small get so much press and traction, but this is a 120 patient trial. Is that right? No, 160 patient trial, followed out to 14 years. So 80 patients randomized to usual care with type 2 diabetes and albuminuria. 80 patients randomized to multifactorial systematic clinic intervention. Intensive lifestyle at every clinic encounter, intensive lifestyle counseling. An aggressive A1C target, pretty aggressive total cholesterol target, also triglycerides, blood pressure, and everybody got aspirin. And if you do that, 50% relative risk reduction at the end of the trial, 8 years. These patients came off protocol and were followed an additional 6 years, and during that time these curves continued to diverge, so that by the end of 14 years, almost 60% major adverse cardiovascular event reduction. Small trial, small numbers, but it really does tell us what we cardiologists want to hear, is that the things we hang our hat on every day actually appear to work. And I'll just finish with this. This is a project we did with the American College of Cardiology. We developed a primer for the management of diabetes from a cardiovascular that's used for fellows training and for board certification, for maintenance of certification, so you can actually get MOC credit for going through this course, where we target each of the individual therapeutic targets, focusing, including, but going well beyond A1C. So with that, I'll finish. You know, we can't get away from diabetes until we know better what we're doing with glucose. We need to make darn sure we're treating LDL cholesterol, blood pressure, and antiplatelet therapies for those with indication. And stay tuned for the clinical outcomes data that will be coming in a flood in the next 4 to 5 years. I'll be happy to answer any questions. Look like we have just a few minutes.